as you can see right here, I got a little QR code. If you guys scan that QR code on my screen, or on your screen at this point, what it does, it has all the links for my social media, as well as there's one link there for my Thingiverse profile, which is a website where you can just put STL files and people can just download them for free. And there are a couple interesting ones in there. One specifically is for the Gothic Arch Tracer, which I'm going to be talking to you guys today about a little bit. And if you are interested in making those yourselves digitally, these are the links to download those files for free, absolutely for free. Okay, so our webinar today is going to be on removable prosthetics. I'm going to talk a little bit about everything, not just basically these are the teeth, we're going to set teeth like this, and this is what makes it better or makes it worse. I want to take you guys through a little bit of a clinical as well as a technical overview of removable pros, tissue support removable pros, for a couple of reasons. One of them, because I'm a denturist and oftentimes I do work chair side, because I'm in Utah, I mostly work with residents as a consultant, but I do quite a few clinical things. And what I've found out over the years is that in order to properly do a job of a technician, you need to have a proper understanding of the clinical side of things, as well as in reverse, in order to properly do clinical workflow, you need to make sure you understand how technicians operate. And I try to show it to our residents up at University Hospital, and it makes their job a little bit easier, and it makes it for the lab a little bit easier as well. So first thing that I usually talk about is that everything that we do in dentistry has a certain type of foundation, okay? For removable prosthetics is no different. In order for us to do a proper job for prosthetics, we need to have a good foundation. And if we don't have that good foundation, no matter how beautiful the structure is, it's going to fail. As you can see right here in this picture, I like using this picture because you have all this beautiful tower. It's very ornate. It's very, very famous. But look the way it's leaning, right? Because the foundation wasn't done properly. Same thing with dentures. If we don't start with the proper impression techniques, we will not end up with a good denture. We can do a bunch of corrections. We can fix some things, but over the years, you'll see that it's a lot easier to start with a proper initial impression, and it will make things go a lot easier for you, okay? So common issues in complete removable pros is that we are basic things. I'm not showing you guys anything new here. And a lot of times, the reason why I'm trying to show you the basic things is because we spend so much time trying to pay attention to all these complex protocols like model analysis and everything else, and we forget the very basics, Dentures don't have enough lip support. We don't show enough teeth. We don't have a good buccal corridor. We have too much buccal corridor that's filled in. Dentures are looking too flat, and so on and so forth. Okay, communication is definitely the key. The majority of issues that I see have to do not only because improper clinical or laboratory workflow, but no communication between the clinician and technician. Okay, because I've been guilty of this myself. I can't even tell you how many times. We assume certain things. I often assume that my technicians already know what I'm talking about. I assume that the clinician already knows what needs to be done, and I omit certain things because in my mind I think, oh, you know what? They already know this anyways. I shouldn't be telling them this because it's just going to make me look like a condescending person, But in reality, try to kind of have a feel for things, and if you're seeing things that are wrong, make sure you communicate. Make sure you try to educate each other. If you're a clinician and you see things wrong on the lab side, try to teach them the clinical aspects. If you're a tech and you see things that are coming in that are not completely correct from the clinical side, make sure you try to educate them on that. When you work as a team, things go a lot better, okay? So guidelines for maxillary impression. Basics, again, you want to see all anatomy. And when I say all anatomy, I don't mean the esophageal impressions, because I've seen those before as well. What I mean is that you want to see the peripheral roll. You want to see the hamular notches. You want to make sure you have enough in the posterior palatal seal area that you can actually go from there. Because if you don't take impression, back far enough, when you're fabricating a custom tray, the tray is going to be too short, and then the denture is going to be too short. Creates more issues than you want. Okay. Same thing with the lower. You want to make sure you have the you want to make sure you have the entire vestibule impressed. You want to make sure you have your retromolar pads, which is very, very important. One of the major things that I usually see is there are no retromolar pads in the initial impressions. Okay, and then they say, well, it's just for custom tray. Well, it's not that simple, guys. You need to make sure everything's there, because it will make your job so much easier, and I guarantee that to you guys. Okay. I see this kind of stuff sometimes, not as much anymore, because with social media and everything, and with education, people are getting a little bit better, and they don't want to see pictures like that anymore. But I'll get a case like this where you have completely obliterated anterior portion, and you don't have sufficient buccal vestibule taken, and then they'll say, well, this is just for a custom tray. Well, it's very difficult to make a good fitting custom tray from this, and you're going to have to do a lot of adjustments and a lot of additions chair side in order to create a custom tray that's somewhat fitting from something like this. So if you see something like this coming into your lab, don't just make an arbitrary custom tray. Communicate with your clients. You know, what I did here, I called the doctor, and they're like, well, the patient's a gagger, and we couldn't get a good impression. Well, I said, well, you know what, if you're having an issue with a patient who is a gagger, you can't take a good impression, there's a possibility that you might want to try doing an intraoral scan. Well, if they don't have an intraoral scan, maybe try to, you know, there are places where you can have people come in with intraoral scans and they'll scan them for you. We've utilized that service before. We had our own intraoral scanner. Or, you know, try to utilize different techniques for trying to reduce the gag reflex on patients. A lot of it is, you know, using little tricks like telling patients. My favorite one is when I put that in, put the impression material inside the patient's mouth. I tell them, you know what, make sure you do not think about pink elephants, and that's all they can think about at that point. So that distracts them. You can give them a towel to pull on, you know, to pull apart. You can have them lift their feet up. You can put a little bit of salt in their tongue. There's a lot of different techniques that you can utilize. Sometimes none of this works, and then you're going to have to think about, are you going to need to do something different for treatment modality for this patient? So if you're doing a full denture for this patient, you can't even take an impression, there's a possibility that that patient might not be able to wear a full palate denture. So you might need to adjust your treatment modality for that particular patient, okay? Something like this, you know, you take your tray and it's not going in far enough because you see that anterior vestibular portion is very, very thick, but the back, the hamular notches are missing on one side and the tuberosity is missing on one side. Well, this is not going to create a good custom tray either, okay? I see this very often, guys. Most of the time, clinics have dentate trays. They're usually disposable dentate trays. Not a lot of clinics, unless it's a denturist practice, have edentulous trays. And when you use a dentate tray and you don't adjust it, oftentimes what will happen is that it'll end up pushing on the retromolar zones and it will create indentations there. And what you learn over time is that taking a good impression, a very passive impression of the retromolar pads is pretty much critical for best possible mandibular retentive denture, okay? If you look into books or articles or whatever by Dr. Jiro Abe, he wrote several books on mandibular suction effective denture. I read some of those books. I'm nowhere close to understanding that system completely, and I'm not an instructor for that system. And but there's a lot of cool things that you can utilize there for your practice, and it will definitely help you, and it has helped me quite a bit as well. Okay, and I see this also quite a bit. You know, they'll take an impression with a dentate tray, they'll perforate the area of the posterior palatal, of the retromolar pads, and then also the assistant oftentimes will try to pour up the impression, and they don't create enough base to it, and that causes issues as well. That's why I'm a big proponent of boxing up all my impressions, because it takes a lot of guesswork from the technical standpoint. Okay. We do this sometimes, not as often as you might think. So if you have a tray that's a little bit too short in the areas and patient has like a V-shaped palate, a lot of times you can use a little bit of either wax or use a little bit of putty as we did here to kind of form the tray for you. So when you take and you cover the whole thing in alginate, it takes a better impression. Now with alginate, one thing to remember, you're looking for something that's going to be overextended. Now, not to the point where you don't see any anatomy. That's why we're utilizing two types of alginate here, but you want something that's going to overextend your impressions because it's going to show you how the tissue moves. It's going to show you how far back to cut the tray. That old adage about, just taking things 2 millimeters from the depth of the vestibule and making the tray that short, it might work on the maxillary impressions and the maxillary models, but it does not unfortunately work very well from my perspective, from my experience on the mandible. So you can see we have one right here for the maxilla. Now for the mandible, if you are utilizing a dentate stock tray, okay, what I recommend you guys do is make sure you cut out the areas of the retromolar pads like you see right here, and then box it up, well not box it up, but border mold it with some surgical wax or rope wax or something like that, because oftentimes you're also going to be reducing the vestibular length of the trays and the lingual one as well, because they're going to become too overextended. Okay, and as you can see right here, this is what we did. Right here, the alginate in the middle is basically, I'm using it as tongue filler to make it a little bit easier to pour up if you're not boxing up your impressions, or even if you are boxing up the impressions, it'll actually make it a little bit easier so you don't have to fill in this whole thing with block out putty. Okay, and you can see that I kind of marked the outline with Thompson indicator stick, a stick, in order to fabricate my custom trays a little bit easier for me. Okay, so I can read the anatomy just a little bit better. Now, what type of alginate you guys should be using? I can't tell you 100% which one will work for you, which one won't work for you. I can just show you guys what I use and what has worked for me over the years, and what's also not very expensive, because price points are also important. Okay, so I use two types of alginate. I use Zermac neocolloid. This is for me a light body alginate. So I treat my alginates like I treat my polyvinyl, light body and medium body, or ultra light body and light body, depending on how you want to look at it. So neocolloid is something that I use for the injection for my light body, and Hydrogum 5 is what I use for the base of the impression, basically your light or medium body, right? For your medium or heavy body. Some people will view it that way. Okay, so you can actually go and buy special syringes for dental impressions. I prefer just to order these 60 milliliter catheter tip syringes from Amazon. They're a lot cheaper than buying dental ones. And what I basically will do is I'll mix up the neocolloid and use that in that syringe to inject into the vestibule, to inject into the mylohyoid regions sublingually, to inject on the top of the palate. Sometimes it doesn't work very well because it'll start dripping. But for the buccal and vestibule, and for the facial and for sublingual, guys, this stuff works amazingly, and it takes really, really detailed impressions of the areas. Okay, and then like I showed you guys before, if you're using dentate stock trays, you want to modify them to look sort of like this. Now these trays are called framework cutback trays. Were designed by Dr. Abe, and they're designed to reduce pressure on the retromolar pads and not to create too much pressure on the buccinator and on the external oblique ridge of the patient, in order to not overextend things too much, but also take really good, really, what's the word I'm looking for? It's too early for some reason, even though it's like 10:30 already. Detailed. You get really nice detailed impressions with these type of trays. Okay, and you can see how this is formed in order to make sure you're not overextending things too much. A lot of times you will have to actually trim this area as well, where the mentalis muscles are, because it will actually press a little bit too much, but it's not always necessary. And the handles are designed in such a way that the patient can actually close their mouth. there's a lot to be said about open versus closed mouth impressions, because in order for us to have the best fitting mandibular denture, you need to make sure to capture your retromolar pads in the relaxed position. Because oftentimes when we're taking our initial impressions and when we're taking a lot of times our final impressions, our patients are like this, they're wide open, okay? When you're wide open like this, your retromolar pad is very, very stretched. But majority of our patients, when they're wearing their dentures, they're not walking around like this, right? No, they're in relaxed state. And if you have a denture fabricated for a stretch state and you have a patient wearing in a relaxed state, then you're going to have issues with stability, okay? So make sure to have your patients close as much as possible when you're taking mandibular impressions. It will help you obtain better, more relaxed position of your retromolar pads, which will also make it a bit easier for you to define your plane of occlusion, because we oftentimes will hear, right, that our plane of occlusions need to be about halfway up to 3/4 of retromolar pad. Well, if our retromolar pad is in a relaxed state, our plane of occlusion is going to be proper. But if our retromolar pads are in a stretch state, well, you're going to see it go all the way up to your hamular notches, and then your plane of occlusion is going to be too tall, and it's going to be disbalanced. Okay, so it's one of the things you need to watch out for, guys. Okay, so this is just another view of a stock tray that has been modified to look like a frame cutback tray. So obviously, I took a little bit of a torch and I moved the handle so it's not interfering with that lower lip as much. Sometimes you can actually cut things a little bit right here as well. I cut back areas of the buccal shelf, and I cut back things in the area of the retromolar pads. Okay, this is just another view of another tray that I already showed you guys. Now, if you're using edentulous trays, you can modify them in certain ways as well. These particular ones, these are massage trays. They're thermoplastic ones, so you can just throw them in a water bath, hot water bath, and you can thermoform them like this, okay, to get better results. And you can also, if they're too overextended, you can cut them. These areas right here, they're a little bit more difficult to work with, but usually it's not too overly problematic. I still try to address the least amount of pressure for retromolar zones, but oftentimes I see people use these for definitive impressions. Okay. Now, using some type of thermoplastic material to do border molding, it also works well, just like I showed you guys with the putty. Now you can use thermoplastic beads, or here I'm using isofunctional, or you can use Kerr compound to get proper borders when you take in initial impressions, as you can see right here. Now, when you're working with your patients, it's important to try to view the tissues, okay? So you can see that where I'm looking right here, I'm trying to visualize where the mentalis muscles are. I'm trying to see if I have a lot of movable tissue that needs to be addressed. I'm looking at the position of the retromolar pads. I'm seeing how they're stretching, and I'm seeing how the tray is going to fit over that whole area, okay? There are going to be several types of trays that you guys are going to be using over your years in practice, whether it's clinical or it's going to be in laboratory. Most of the time, when I first started out and when I went to school, and when I learned to be a tech also, were space trays, right? The trays that were kind of loosely fitting on the models. We put like a bunch of base plate wax on it, and to make sure we have enough space for everything. The issue with those trays that I have found down the line is that oftentimes we will overblock the areas, and we'll make trays not just too long, but with overblocking, it makes the trays too wide. So when you make trays too wide, when you try to do border molding, the width of the tray does not allow for the proper molding of the compound or the impression material. So in order to fix that, we usually ended up cutting the trays even shorter, and then you have to end up building more compound on top of that to allow for that movement. So I don't like doing space trays so much, especially as of late. I've been doing quite a bit more digital workflow custom trays. And what that allows me to do is really minimize the blockouts where they need to be, and I can do a 1 millimeter impression gap for them. So it makes a very nice close fitting tray. And I can actually check with the tray oftentimes if I'm getting suction on things, where I don't have to add a ton of material and I don't have to do border molding even half the time with these things. And I get really, really good adaptation of impressions and better fitting dentures down at the end. Now with window trays, that's something that I've utilized a little bit, but I actually started kind of getting away from those because it's just too much of a mess in my opinion. Window trays are usually utilized for cases where you have, let's say for example, you have a patient with a Kelly combination syndrome. So patient will have a very flabby ridge on the anterior, and you're trying to stabilize that ridge as much as possible. So if you're going to be doing a close fitting tray, you're going to push on that tissue one way or the other, and it's not going to be in relaxed state. So oftentimes we'll make a window tray where you can actually fill it up with the impression material from the outside, so you're not putting a lot of pressure on that loose tissue and resorbed maxilla or mandible, whatever you're dealing with. Now, if you're injecting into the mandible, gravity is working for you, and you can actually take a pretty good window tray impression. When you're dealing with the maxilla, oftentimes that stuff is just going to start leaking back, and you're trying to support it with gauze, and I've had issues with it. So what I basically do now, if I have an area that I need to impress and I need to stabilize that tissue, I do a close fitting tray everywhere else, and in the area where the tissue is too loose, I'll give extra block out. What I basically will do oftentimes, I don't even do it digitally, even though the tray is going to be fabricated digitally. I basically will add a little bit of wax to the model that I'm working with, and then I'll scan that in. So when I'm designing the tray, it will uniformly design the tray all the way around without having to change and doing reliefs and stuff like that. So adding a little bit of analog workflow to your digital oftentimes will save you a little bit of time and will make things flow easier. Same thing if I'm doing a custom tray for a partially dentate patient for an RPD, I'll actually block out the stone cast with some putty first or some wax and then scan it in. And then gives me extra room around the teeth so I don't break off teeth when I take the impression. So little things like this will go a long way when you're trying to accomplish certain things. Okay, understanding the type of material that you guys are using. Thickness of space for impression materials is different for different materials. Obviously for alginate you need more room than you need for polyvinyl. And depending on what type of polyvinyl you're using, the amount of room is going to be either less or more. If I'm using heavy body and I'm trying to do border molding with heavy body impression material, if I'm talking about polyvinyl here, now I'm going to need to reduce my tray a little bit away from the peripheral in order not to overextend my impression. Because if my custom tray is almost to the full vestibule, if I'm like a millimeter, maybe 2 millimeters away from the vestibule, and I'm using heavy body, well, what's going to happen? That heavy body is going to push even more into the vestibule, and I'm going to end up overextending my impression. Okay, if you're that close to the vestibule, 1 or 2 millimeters, I would recommend either not border molding at all or border molding with medium body. Okay, you'll see things like zinc oxide eugenol paste, which are great from the clinical standpoint. You can take really good impressions. They're not that great for patients because they actually, especially the zinc oxide ones, they kind of burn the tissue a little bit, but they take really detailed impression. From the laboratory standpoint, man, they suck, guys. I mean, it's really difficult to work with. I only worked with it once, and it's a nightmare. My favorite ones are going to be your polyvinyl impression materials and algins. Those are the two things that I mostly work with. Okay. Now, my static outline. My static outline is an important concept to follow. Not exactly, but at least it's important to understand where things are going. So when you're adjusting your custom trays, it will make things a bit easier for you guys to take a good final impression. As I mentioned, when you take your first initial impression, it's going to be overextended. So you need to be able to read the anatomy to see how far back you want to shorten your trays in order to get the best possible results, right? Now, if your initial impression is really overextended, like you see right here, so I don't know if this was alginate or just heavy body polyvinyl that was just really pressed into, but I can't see any kind of frena. I can sort of see where the retromolar pads are. I can't really differentiate where my masseter muscles or my buccinator muscles are like that. So it's important to take a good initial impression, like I mentioned before. And if I take just an alginate impression, like a regular alginate, like nice heavy body Hydrogun 5, put it in there and push things, it will probably act a lot like a heavy body polyvinyl, where the anatomy is going to be somewhat not very visible. But if I take the same type of patient and I mix a little bit of that neocolloid injectable in combination with Hydrogun 5, now the results are completely different. Okay, that's the same patient right here, but you can see all the mucosa fibers and everything else running through there. Okay, so you can see right here that we had a little bit of overextension on my frame cutback tray on the anterior zone. So I should have probably trimmed that a little bit better, but I made a note of it and I followed it down the line when I was making a custom tray. This is a little video that I recorded for.
So I just wanted to show you this. So we took a couple of impressions on this patient.
Hopefully you guys can hear it pretty well.
Impression was done in just a regular Hydrogun 5. And you see there's not a lot of detail. I mean, it's a really good impression. Just a little bit of the retromolar area is missing here. But the tissue is kind of just pushed out, and you can't really tell where the mucosa is and where the everything else is.
And that's considered a great impression, guys. Don't get me wrong.
Here, this is a mixture of Hydrogun 5 and neocolloid. If you look closely, you can really see the crinkling of the mucosa and everything else. I mean, the tray is showing through a bit right here, and a little bit over here as well. But this is below the mentalis muscle, so it's not going to be problematic. We're going to have to trim that up anyways for the custom tray. One thing I don't like is the tray showing through on the retromolar pad region.
Yeah, so on retromolar pads, you know, we're trying to make them as least displaced as possible, right? So if you have tray pushing in that zone, that doesn't make it as good. But since it's still just an initial impression, even though I try to emphasize, make sure your initial impressions are really good, little things like this are not absolutely critical. You know, you can make adjustments for them. But you can see with that tray, I could tell right here exactly where I need to end the tray, because I have my buccal mucosa right here, and I have my a buccal shelf. So I want to make sure that it's sitting on my buccal shelf and not pushing into my muscles here, because I have my buccinator muscle right here and I have my masseter muscles right here, and I can see my frena fairly well. Even though they are a bit extended, overextended, I can still visualize them pretty well, and I can actually do a fairly good job with designing of my custom tray. Okay. 1 sec. I think I accidentally. No, everything's correct. I just kind of skipped the slides a little bit. So what I'm basically going to show you guys right now is how to do the myostatic outline by the book. So I basically, the way I learned it, I found this PDF online that talked about myostatic outline, and I started kind of outlining from that. And if you actually buy Dr. Abi's book, his outline for this custom trays is going to be different, but a lot of things, well, many things, I wouldn't say a lot, but many things are very similar in the myostatic outline design of custom trays to the Dr. Abi's design of custom trays. Okay, so basically what it shows you is you mark the crest of the ridge. The reason why you mark the crest of the ridge, it makes it a little bit easier to identify the middle and where your retromolar pads are going to be starting. You don't necessarily have to do that. It's more of a textbook thing. I'll be honest with you, oftentimes I'll just mark the retromolar pads and I don't even worry about the crest of the ridge, okay? Now, you want to mark your mylohyoid ridge because your trays need to be extended all the way to the mylohyoid ridge. If they're too short, you're gonna have to start adding material to it. If they're too long, you're going to be pushing your tray too far into the mylohyoid. Your denture should probably end about 2 millimeters below the mylohyoid ridge. This will allow for that compensatory suction in that area, but it will not over push things onto the mylohyoid itself, okay? Okay, next thing, you mark the external oblique ridge. Marking the external oblique ridge is a little bit difficult sometimes because it's not very visible. If you take a good impression, you can often see the nice definition of it, but if you can't, what I've read is that if you take the model and you start playing with the light a little bit, you can actually get a shadow hitting on that transition. Personally, what I do is I kind of eyeball it a little bit. I see where it starts to kind of go upward a little bit, and I stop right there. Because for me, and this should be the same way for everybody, designing a custom tray and fabricating a custom tray is an approximation. It should always be adjusted and muscle trimmed intraorally. If you don't do that, you're running a risk of overextending your impressions, okay? Now we're gonna mark all our frena, and then we're also gonna mark our mentalis muscles. I generally will extend my trays about halfway down in the mentalis muscles. Some people will cover them completely with just a little bit of blockout. I was taught a little bit differently, so I just kind of cover them about halfway. For me, the mentalis muscles are the easiest ones to see, because even if you overextend the impressions, you're going to see somewhat of an outline of mentalis muscles in those areas. Okay, so I have the frena marked, I have the mentalis muscles marked, I have my external oblique ridge, I have my retromolar pads and my mylohyoid. Now you've noticed that we've marked the retromolar pads about halfway up, because past the halfway mark, your areas are going to be of the retromolar pads are not going to be as stable. So if we have the tray that's going to be pushing too much on that, it's going to maybe distort things a little bit for you. Also, sometimes we take impressions with the mouth open too much, so those areas might be too stretched. So it's a good idea to kind of design your trays that go halfway or 3/4 up the retromolar pads. Okay, if you have the lingual frenum, make sure you block it out, right? Make sure the tray goes above it. Okay, I don't mean block it out this way, but make sure you cut the trays that are not covering that, because that lingual frenum, every time they're going to stick their tongue out, they're going to flip that denture right out of the mouth. Okay. Okay, we already talked about the mentalis muscle, and I talked about the retromolar pads, but you want to make sure you connect the areas all the way together. I'm going to show you from a little bit different view. So you have your mentalis muscle going above the frenum. Okay, you don't want to go across it because it's going to be too long. So we're actually just going to do an area there, and then you do like about a 45-degree connection from above the frenum to the external oblique ridge, to that buccal shelf, and you do like a semicircle connection to the retromolar pads. Why don't I just go directly across from here? Because my masseter muscle is right here, and you also, if you look closely, you can see an area here. There's a sinew here called the simia sinew, which is a very kind of tough ligament, which can also just completely throw the denture away. So doing this kind of connection for the custom tray will allow for better adaptation and for better impression. Okay, and on the mylohyoid, you can connect things kind of semicircle this way. So it's fairly intuitive. If you know the shapes of what the denture should look like, you kind of follow that shape, making sure you avoid all the major muscle connections. Okay. As you can see right here, so the masseter is going to be right here with that sinew, and then you're going to have your mylohyoid right below the mylohyoid ridge, and you're going to have your buccinator attachments right there, and the depressor anguli oris. That's the one where you go from the buccal frenum about 45 degrees down to the external oblique ridge, and you have your mentalis muscles. And pretty much by avoiding all of those things, you fabricate your custom tray. And one of the things that I often see done incorrectly, I see the handles are going 90 degrees forward. Okay, if you want to do a handle that goes 90 degrees forward, you have to raise the handle quite a bit higher in order to do that. Because when you do your O movements, when taking those impressions, you're going to end up causing some major issues with capturing the anterior vestibule. Okay, so you can see that right here. Trays are trimmed. Now we do some little adjustments chair side, but if your trays are adjusted properly, so this is just a tray. I'm talking Russian to the patient because she doesn't speak any English. But you see, I'm getting suction on the tray alone. So with that type of tray, you can basically just take that, cut the handle off, and just start setting up on that if you wanted to. But we wanted to make sure we get the best possible thing, and we wanted to create a master cast. So we took a really, really small, ultra ultralight body wash on this, and then we poured that up and got good suction on that patient. So creating a really good initial impression will take it a long way to get a good final impression and to get a good denture down the line. So there's closed mouth impressions, there's open mouth impressions, but as you can see right here, with the closed mouth impressions, you can get the tissues in function and also in relaxed states as well, and get a lot better adaptation of dentures. That's why I kind of like the BPS technique. I don't generally use that myself, but it's a really good way of doing things. And you'll notice, guys, if you take a reline impression of a denture, you oftentimes will get a lot better fit than just taking a new impression. Why is that? Because a reline impression is a closed mouth impression. It gets a better function and better relaxed state of the tissues, okay? With open mouth impressions, you can kind of see what you're doing and everything else, but not a huge fan at this point, I'll be honest with you guys. Custom trays, right? There's so many different designs of custom trays out there. And I did this right here just to make sure. I've kind of tried, read some articles, and I try to see what it takes to fabricate these. And some of them are pretty simple. Some of them are overly complicated. Like, look at this one. You got 2 layers of different wax and everything else. Honestly, guys, use whatever works for you and your patients. For me personally, I like close-fitting trays at this point of my career, and I'm getting pretty decent results with those. You do whatever you think is better for you. Okay. Just a little thing I wanted to touch on partials. When you're doing partials, sometimes when you have severely angulated teeth and you take a polyvinyl impression, that thing is going to lock in, and you're gonna have to drill the tray off. Sometimes it's better just to take a good alginate with some of that injectable material and some of that tray material, and you'll get a good impression for the PDF, for the RPD, not PDF. Okay, couple of other things. You want to make sure that the tissues are the most possible relaxed state and the most possible clean state for when you take your impressions. So removing dentures 24 to 48 hours before taking, this is more important for final impressions, is ideal. And you want to make sure your patient is actually, when they're wearing dentures, there's a couple of schools of thoughts here. I used to be, like when I first started in this career, I was a very black and white kind of guy. Now I'm more of a gray area kind of guy. There's always a little bit of gray area. Now, obviously, if your patients don't take their dentures out ever, the tissue can't breathe and you can get fungal infections like here, you got denture stomatitis. So I highly recommend patients take out dentures out at night. However, there's a caveat there. If the patient has a compromised airway and you will take the denture out and collapses the airway, it will cause them to get like sleep apnea and stuff like that. So sometimes we'll recommend patients don't do that because, you know, breathing is more important than a fungal infection here. So I'll recommend they maybe wear their dentures at night, but take some time during the day to take the dentures out and have the tissues heal, okay? Make sure tissue is free from denture adhesive. Guys, so difficult to take a good impression when you have a bunch of adhesive in there, and it ruins your impression, it ruins your stone, and it's just a total nightmare, okay? Dry tissue with gauze before taking VPS impressions. On that, honestly, guys, it depends on the material you're using. Some patients, some materials are more hydrophobic and some are more hydrophilic. You know, these newer impression materials are fairly hydrophilic. So unless you have like a ton of saliva in there and it's all very stringy and everything like this, I usually don't worry about it. I'll run a quick suction to the patient's mouth and take the impressions, get fairly good results with it, okay? These pictures were given to me years ago by somebody, and I'm sorry I can't remember who gave these to me. I remember some from UK, and there were denture schools there, and there was one of the projects that they made, and I would maybe screenshot these guys because it tells you exactly which areas to get and what movement of the mouth to do in order to get these good impressions. Now, remember, these are already after the trays have been adapted and the trays are fitting well. If you have a tray that's not properly adapted, taking all these movements are not going to do you any good if you have a severely overextended or severely underextended impression, okay? Same thing with the maxilla. All these areas are fairly important and everything else. Now here you're seeing that they're using a little bit of a thermoplastic compound, like Kerr compound, in order to get border molding done. And these are probably not the closed fitting trays. They're probably kind of a little bit far away from the periphery, and they're using that compound also to give a little bit of that pressure onto the posterior palatal seal area. Now remember with this, there are kind of a couple of schools of thoughts here. Like if you do this, you don't have to, apparently you don't have to cut out the butterfly into your stone to give that additional support because it's already pressing into it. I know people, including myself, who cut the butterfly in no matter what, because I can't tell half the time if that thing is present or not. So I'd rather have a little bit too much pressure on the posterior palatal area, and if it's too much, we can always reduce it, because adding to it is a lot harder than removing from it. That's my personal point of view on something else. Let's look at a couple of different mistakes that I see with these impressions. For this particular impression, even if the tray was done properly, using improper impression material will create improper master cast. You can see that we're using heavy body for the base of the impression, which I highly not recommend, because you're going to end up with overpressing of tissue, and it doesn't also create very good detail. They tried to correct it with a little bit of light body, but with light body, what you need to be doing is covering the entire surface, because otherwise you're going to end up with steps, like you can see right here. Okay. Here they were using a perforated tray with light body. When you do that, basically what happens is just all the material runs out of the tray, and you get all these voids in it. Okay. Here they were not using adhesive when they were trying to do a reline impression, and all that material right here will flake off when you try to actually pour up the impression, so it's also not going to work. Okay. Here we have insufficient custom tray, was too short, and also the material was too short in this area, and the material was used not properly. They were adding a little bit of material in little areas and not enough pressure to kind of smooth things out. That's why you get all these bubbles. Also, the tray wasn't trimmed properly. You see how you have the tray showing through here? That's what I was talking about, guys. When you use too much block out on your custom trays, what will happen is that even if your length is correct, you'll try to do the movements of the buccal and the facial lip movements and the cheek movements, and will actually end up hitting the tray as it did right here, and it won't allow for the proper roll to take place in order to take things. So for this, even if you think you've got enough room here, you're going to have to reduce this quite a bit down and do more border molding in order to provide that proper roll. Okay. Same thing here. We got voids. We got tray that's too wide. You see how wide this is right here? So we're okay on the height, but the width is too much, and it's not allowing for the proper roll. Using light body insufficiently, got deficiencies right here as well. Okay. My favorite thing to do is using duplicate dentures to take final impressions, guys. Now, obviously, not every denture is going to work. Some of them are so far gone that it's easier just to start from the beginning. But then oftentimes, even the worst fitting denture can make a pretty good custom tray, and also it allows you to get pretty good vertical dimension as well on these things, and allows you maybe oftentimes to go directly from duplicate denture with the impression to go directly to a try-in if things are somewhat where they need to be. Okay, so we print those nowadays. I don't do those by hand anymore. And then you taking an impression with a couple of different things. Sometimes if we're doing things chair side, what we'll do is we'll just take polyvinyl. If you are doing things where you're going to send the patient out to have them wear this for a while, we're going to use tissue conditioners. One thing to understand, if you're printing a denture, there are issues with using tissue conditioner for printed dentures. I'm trying to run some tests on this new material that I'm using for duplicate dentures, see how well it sticks to it. I haven't done it yet, but as of right now, what we generally do with printed dentures, we'll just use polyvinyl with adhesive, and that has been working pretty well, and we'll just do impressions chair side. But sometimes you could do these for long-term impressions. I generally will use that for relines of dentures that patients have been wearing for a while. So we'll put that in, we'll look at the areas where we have overextensions sometimes, and we'll just trim that back. So I'm kind of using it a little bit as fit checker. Okay, and then we'll take a new better impression if you're just using tissue conditioner. Sometimes you can just use impression material like ultralight body for fit checker. It actually works a little bit better, so you don't have to peel out all that stuff. But that's the idea. You put that in, have the patient wear that for a while, and then you do a reline. But if you have an insufficient areas of your duplicate dentures, you need to make sure to make them sufficient. So here I'm using a duplicate denture and I'm adding a little bit of thermoplastic compound, like Kerr compound, to do that. And look how underextended that was. If you make a denture that this underextended and use that for your final impression, you're not going to get good fits out of it. Okay, this is my new favorite thing to use, these thermoplastic beads, because Kerr compound is actually it works, but it's kind of brittle. This stuff is not as brittle, okay, and it works a little bit better. Look how I'm doing a reline for this particular patient, and look how much I had to extend his dentures because of what? It all started with the initial impression, guys. The initial impression wasn't done properly, the custom tray wasn't done properly, and the final denture wasn't done properly because it was too short, and it just wasn't very attentive. By adding this compound to this patient's denture, I got suction right away without even adding impression materials yet. Okay, so it's important to look at your anatomies. Look at this guy.
It's not moving.
Look, there's no impression material, it's just a little bit of thermoplastic beads in there. Okay, now you're going to take all that time clinically to make a really, really good impression. It really sucks when you send all that to the lab and they will just completely obliterate your impression by overcutting everything. So if you're on the lab side, guys, make sure you box up your impressions. It will go a long way and it makes it really easy. Okay, I can teach somebody to box up an impression with this technique in minutes. Okay, all I'm using here is just some magnetic tape, and I'm using a little bit of R-time dough. It's kind of like Play-Doh here. Okay, and you can use it with algins as well. It makes it really easy. The only difference with algins, guys, you just want to make sure that you kind of build it up around the algin and not press the impression into the R-time dough, because it will kind of pushes things out a little bit too much because it's got a little bit of density to it. Okay. Now with master casts, there's certain things you want to follow in order to alleviate issues. Now the landing areas, you want them to be about 5 to 6 millimeters for a couple of reasons. Number one, it makes it really easy to visualize where your border molding is done. Okay, if your tray is over trimmed, if your model is over trimmed, you're going to over trim into the border molding, and it might not be properly sealed at that point. So that landing area shows where things need to end. Also, when you're actually flasking your cases, if this is too thin, there's a chance that area can fracture when you're actually pressing the acrylic. I haven't seen that happen personally, but I've heard people talk about that. Okay. Now the depth of the sulcus, it talks about being 3 to 4 millimeters by textbook. I generally look at the undercuts. So when I see the things go up, this is where I stop, because once it goes up, it starts going over a little bit. Once it starts going over it, you're going to create an undercut. So I cut it right past that undercut to this point, and that's where I extend my base plates. Now, obviously, if things are overextended, you might have to shorten those base plates, but that's something between you and your clinician. Okay, the height of the master cast, here it says it needs to be 15 millimeters. I recommend having at least 10, because you want to make sure you don't have over pressurized on your models, and you don't want your models breaking when you're actually brass packing things, guys. Okay, this right here, I put that slide in. I honestly, guys, I don't follow this. You know, I just go a little bit past that area, and that's good enough for me, because oftentimes this will be too long and you won't fit into a flask. Okay, maxillary model, posterior palatal seal, we usually go about 2 millimeters past the fovea palatini and go to hamular notches. So it's a good landmark to remember when you're taking your impressions. Okay, now for your base plates, make sure you follow the parameters as close as possible, because it makes it a lot easier for your clinicians to do the fabrication and registration of bite. Okay, so you don't want things too full or too little. You want them to be correct. So I try to do an 80 degrees thing for anterior area. It kind of gives myself proper lip support for my patients. And if it's too much, I can always reduce it more. Okay, I try not to be too bulky, but I try not to be too little either, because adding things is a lot harder than removing it, but also removing a lot of things, it's also kind of annoying. Okay, you can use something like this. Personally, I've used this a couple of times. It's called a papillometer. What it basically does is you place it on the papilla, and it shows you where the lip ends, and you make your wax from about 2 millimeters longer than that. I generally go by 22 millimeters from the depth of the vestibule. Now, obviously, we have different displays for different people, right? Males versus females, younger versus older. These are just basic things you want to follow. But also, some things will just look good and some things will just not look good. Just because the chart says it needs to be 3 to 4 millimeters here or 1 millimeter here, if it doesn't work for your patient, it just doesn't work. So make sure you work with your patients like individuals and not just a chart. Okay, Alma gauge is a good way to utilize measurements if you're using an old denture. However, I generally, if I have an old denture that my patient likes, I will just duplicate it and use that as is. So there's no need for an Alma gauge right here. But if you do want to use an Alma gauge or if you want to take measurements, I've designed this little attachment that you can just buy a $10 digital, what is it called? Digital caliper, and add these to it so you can use that as your Alma gauge right here. So you have your vertical and your horizontal attachments pretty well. So that's also my Thingiverse account. You can just download that. And here we just have the basics, right, guys? We have your wax rim needs to be about 7 to 10 millimeters. This is 7 to 9, but 7 to 10 millimeters from the middle of the incisive papilla facially with that 80-degree angle. And the width in the interior needs to be about 5 millimeters, 5 to 8, and the posterior about 8 to 10 millimeters. Same thing on the mandible. You want to make sure you have proper width and length. You want to make sure things are over the ridge. This is my favorite tool, guys. I love using it for wax rims. It just makes my job a lot easier. And oftentimes I'm right there where I need to be chair side with it, okay? This ledge right here, that is utilized for your maxilla. What you basically do is you place that right on the hamular notches and you heat it up first. You place this on hamular notches and you push down in order to get to 22 millimeters. And oftentimes this will give you your proper camper's plane. On the mandible, it's reversed. So you go up about 2/3 of retromolar pads and you go push on the front until you get to about 18 millimeters to the depth of the vestibule. So that will get you pretty good results. If you have a final impression that, for example, like right here, was taken with heavy body and it's overextended, as you can see right here, you don't necessarily have to start over. What I'll basically do is I'll actually make my wax rims shorter and we'll use those for final impression. So we'll take a bite and a final impression all in one, kind of like the BPS technique. So it will look like this. Now, Gothic arch tracers, guys, especially if you're doing implant cases, but oftentimes for regular, not problematic tissue supported cases, it will get you there 90% of the time. It will allow you to get a better centric relation. I used to do them like this, where I would do a metal screw. Nowadays, I just print everything. So you make wax rims and you make a Gothic arch tracer because it's done digitally. It fits the same model, so you can cross mount it pretty easily. As you can see right here, everything is just mounted right there. We captured the centric relation. And because, especially if you have a case like this, right? When you're using a patient's existing denture and you're using it for final impression. But look at this patient, they're in class 3 at this point. And they're not a scaled class 3, guys. They're acquired class 3. Because this patient's been wearing this denture for, I don't know, 20, 30 years, the posterior occlusion has worn down. And the patient instinctively tries to find a space where they can bite, when they can bite on their teeth. So what they basically do, they'll start moving their mandible forward in order to create that incisal contact, in order to incise the foods. Once they do that, they can start chewing. But if you create a new denture with proper occlusal contacts on the mandible where they can feel that it's actually cutting food for them, you got some efficiency there, they'll start to relax and they'll start to retreat their mandible back into their centric relation. And all of a sudden, you're going to end up with an alligator bite. So with cases like this is an alligator bite I'm describing, guys. So we set up everything, but the patient started to relax, and all of a sudden, the bite's no longer correct. So patients like this, what I'll do is I'll set up the 6 anterior things digitally. Well, actually, I'll set up full upper, full lower digitally. And I'll just cut back the rest of the teeth, just so I have movement, allows for movement. And I'll incorporate a Gothic arch tracer. That way I can check where incisal display is, but I can also capture centric relation as well. I've also designed, this is the final design that I have on the, what what do you call it, on the Thingiverse that you guys can download. And that final design will allow you to take a wash impression and then snap this in and get a centric Gothic arch traces centric relation capture. Okay, I wanted to show you this slide. I'm not a huge fan of phase bows, guys, because in my own practice, I've messed it up more times than I got a good good record. And also with things like this, because you capture it and it looks like this on the patient. I mean, it looks even on the patient, but they're actually they're external auditory canals that look like this. So when you put it back in the articulator, it's going to be canted. Okay, I like using Quasi analyzers a lot better. They work for me. I've even made my own. Here, there's other options right here. One bite is a disposable version, or you can do old-fashioned stick bites. Those work pretty well as well. Okay, these couple of things you can use for canine lines, but basically what I do is I'll just mark the wax rim where the nose starts to end, and it's usually the middle of my canines. Now, model analysis, guys. You know, it could be very complicated, as you can see right here, or we can try to make it a little bit simpler for us. So model analysis allows you to kind of take the teeth and find a best possible area for function and aesthetics, so you don't have to do 2 rows of teeth on things. Okay, and you can also try to alleviate cross bites. Now, model analysis is generally done when the models are already articulated. Okay. Basically, what you try to do is you try to find the middle where the things are ideal, and you try to find areas how far you can shift things outward and how far you can shift things inward. Okay. So it doesn't always work because anatomically things can look really weird. Like if you have the center of your mandible right here, but your incisor papilla is looking right here, then you kind of have to use common sense when model analysis is concerned. Okay. So basically what you want to do is you want to mark your tuberosities and mark centers of your tuberosities. You want to mark the crest of your ridge. You want to mark your incisive papilla, and you want to mark your center of the incisive papilla. And also you want to see where your first major pair of palatal rugae is. Okay. If you see your first major pair of palatal rugae, dots right here will usually be the center of your canines. I oftentimes will utilize that when I'm trying to find the proper mold for my setup. So if, for example, my clinician didn't send me a case that has the canine lines marked, I can take that, transfer that onto the model, and I can take my measurements when I'm choosing my tooth mold size, okay? Technically, the last major pair of palatal rugae is the position of your first premolar. Those are not very visible oftentimes, and I generally have a hard time telling where they are. Basically, what I'll do is I'll look if this is the center of my canine, okay? Usually about 3 to 4 millimeters from there is going to be the end of my canine, and another 3 millimeters is going to be the center of my premolar, okay? So you can just take a ruler and measure it that way if you can't visualize the last major pair of palatal rugae. This point right here is used for ideal positioning. When I say ideal, I do mean ideal, and things are not always ideal in real life. So for me, this is more of an approximation. Okay. So if you run a point from that ideal position of my first premolar, center of my first premolar, through the middle of my tuberosity, that's the ideal position for the middle. Oh, I'm sorry, not for the middle. For the palatal cusp of my molars. So starting from my second premolar. So my second premolar palatal cusp, first molar, second molar. Okay, makes sense? Now I can shift that line inward by actually marking from that first premolar to the pterygomandibular fold, which is just where your hamular notch kind of shifts over about 2 millimeters. That's how far in you can move the palatal cusp of your mandibular teeth, starting from what? Second premolar, because we already have the center of our first premolar mark. Now, how often do you guys move mandibular teeth inward? I generally don't. Most of the time I have to move my teeth outward because resorption of the mandible goes that way, right? And I have to follow that oftentimes in order to correct things. And a lot of times I'll have to kind of correct buccal corridors because I don't have enough movement there. On the outer correction, There's two ways of doing it. One of them is marking the position of the first molar and the first premolar and running a line through there. That kind of gives you the position of how far buccally you can move the position of your palatal cusp of your molars in the second premolar, but that's too complicated for me, guys. I use a much simpler method, and it's actually covered in the modeling analysis as well. We're going to use our buccal cusp. Even though that we mostly work with lingualized occlusion, and our buccal cusp is a non-working cusp, is a good indication of where we need to move the tooth. So we look at the depth of the vestibule. If the depth of the vestibule is our end point, you don't want to move your buccal cusp past that point. You want to stop it right there. That's how far out you can move things and still be functional and still prevent fractures, usually midline fractures, through your dentures, okay? Now, this here will show you the lowest, most stable point of your mandible. It's a special caliper that you can guys buy for I don't know how many dollars, like $100 something, or you can just use a regular caliper with, not a caliper, compass with some wrought wire and do the same thing. And I'll be honest with you guys, oftentimes this is too overly complicated because it shows you like exactly the point where you need to put your first molar. But if you just look at the models, guys, and you look at the very point where it dips down, that's the most stable point for your mandible. That's where you want to put your first molar. It's as simple as that for me, okay? You can see that the models are mounted. We kind of crossed that out. So basically what you're doing, once you mark, I'm going to go back, sorry. Once you mark the position of our first molar, if you're in class 1 occlusion, you can move that line all the way up and show you where your first molar is going to be on the maxilla. I never use that because for me, number one, how often am I always in class 1? I might be in class 2, I might be in class 3. Number 2, I only need that position for my first molar if I'm trying to find the outer correction for my palatal cusp movement. And I don't ever use palatal cusp movement for outer correction. I use my buccal cusp movement, like I showed you guys, depth of the vestibule. So this line for me is not important, guys, okay? So here we see that this is the ideal position for my first molar, and these are the corrections to go mesially or distally. Usually you have about 2 millimeters. You can shift things distally, distally that way, or you can shift things mesially about 2 millimeters and still be within the range of the most stable point of the mandible. Why do we have those corrections? Well, you don't want to end up with diastemas between your premolars and your molars. So this will kind of give you a little bit of leeway if you can go one way or the other. Okay, this is a fancy way of showing you guys how far back we can take posterior occlusion. If we find that very center point of our mandible and we put this little thing on there from Mertz at the very center point, and you actually run that angle, and the area right here where it crisscrosses, the first point where it crisscrosses that mandibular line at 22.5 degrees, that's the last point where you can place any type of occlusion, because past that point it's going to be destabilized and you're actually going to have not vertical forces, but you're going to have a vertical and horizontal at the same time. Now this is way too complicated, guys. I like to use a more simple method. I'm showing you all this just so you guys know it. My method is simple. I looked at the ridge, and this is more like a cannular method. I look at the ridge. The lowest point is where my first molar is. Where my ridge starts to go up, that's where I stop my occlusion. Now, obviously with this, you can go further back because it's more precise. But for me, I like to not overcomplicate things. I'll put my second molar there if I can. If I can, this is my first molar is going to stop right there. I'll have 2 premolars and a molar, or I'll have 1 premolar and 2 molars, which I kind of prefer to do because two molars will have a wider plane of occlusion, not a lighter base of occlusion, and allows you for more masticatory functions. All right. So just a little close-up view. Now, obviously, if you have a very flat ridge, you can pretty much put, I kind of found that this was kind of the lowest point, but if you put your molar anywhere in here, it's going to be fine. And where do we stop the occlusion? Well, in this case, we stop it where our retromolar pads start, because that's where our ridge goes up. Obviously, that's also why we don't put any teeth on our retromolar pads, because it's not stable there. Okay, this is just a little picture from the VITA manual, and shows you like if you go too far past the point, it's no longer vertical. It also vertical and horizontal. It will destabilize the denture. That's why model analysis is important. Now, on the mandibular position of the posterior teeth, it's also kind of, you have the ideal position and how far you can go out and how far you can go in. And that basically what allows you to do is you move the central fossa a little bit out or a little bit in so you can avoid those cross bites, guys. So if you move your mandibular teeth a little bit in and your maxillary teeth a little bit out, you no longer have that cross bite and you're good to go. So the way you do it on the mandible is a couple of things you need to look at. This line right here is the depth of the vestibule, depth of the interior vestibule. You do not angle your teeth past that point because it's going to destabilize the denture. So the basal surface of the tooth needs to sit on the ridge, but the angulation can go past to the point where the depth of the vestibule is. So we're going to go like this a little bit, okay? Now, the position of the ridge is also marked right here. So when I'm setting teeth, I want to set the teeth on the ridge here, and I can angle them as far here as I want to. Now, mandible is different than maxilla because maxilla has a much bigger surface area. You can move the anterior teeth off the ridge because you're trying to build up aesthetics as well, right? With mandible, you're dealing with function a little bit more because you do have a much smaller surface area, so you can't stick those teeth out too much forward because they're going to be on the muscles and everything else, okay? So we mark our canine positions. Oh, no, not our canine positions, I'm sorry. We mark our positions for our first premolars. Now, oftentimes they're right behind the buccal frena if they're visible. Usually they're visible if we have good impressions. If we don't have good impressions and everything's kind of more extended, we basically look at the canine positions. Canine positions are going to be where the ridge is going to start to curve, and we go about 5 millimeters past that point. We're going to end up with our positions of our first premolars. Now it's going to be the center of our first premolar right there on both sides. Those are important because that's going to allow you to mark our first starting point. Okay, and from here we go from the center of our first premolar. We go through the center of our retromolar pads, and that's going to give us what? That's going to give us the ideal position of our central fosses for second premolar, first molar, second molar. So that's the ideal position we want to have it in. That's the most stable. If we want to move those things out a little bit, we still start from the first premolar and we move it out to what? To the buccal end of our retromolar pad. And for the lingual, we can do two things. We can either mark the mylohyoid ridge, which is right here, and draw a line this way, or we can mark the lingual portion of our retromolar pads. So we have the ideal, and we can move things buccally, and we can move things lingually. Generally, I don't move things buccally too often. I'll end up move things lingually a little bit. You don't want to move them in too much because you're going to end up encroaching in the tongue space. Encroaching, not encrouching. Crouching can be a tiger and a hidden dragon. Encroaching into the tongue space and causing things like speech impediments and causing tongue biting. So it's important to follow that lingual border quite closely. Okay, so this is where we see ideal area of central fossa, buccal correction, and lingual correction on there. Okay, now obviously if we have deformities like our something happened to this impression, or maybe anatomically is like this, we have our crest of the ridge right here, but our retromolar pad is right here. Well, obviously we can't utilize that because, well, it doesn't match up at all. So use common sense, obviously. So this is just a little thing from Mertz Dental, where they show you the ideal positioning. So you see how it follows the ideal position from the standpoint of the position of maxillary teeth with the correction inward with the pterygomandibular fold. And we can also see the ideal position of the buccal when utilizing just the buccal cusp over the depth of the vestibule. Here you have the correction that I showed you guys when you're utilizing the palatal cusp, which I don't use. So we have ideal, inner correction, which I don't use. These are the two lines on the maxilla that are generally usable, guys. So the right here for the middle is ideally, and you can stick out your buccal cusps on the premolar, the second premolar, and the molars a little bit out, so it's to the depth of the vestibule. And on the lower, I just showed you guys, you go from the center outward and inward, not passing the mylohyoid ridge, so you're not encroaching on the tongue space. So It looks complicated, but if you do it a couple of times, guys, especially if you don't get into like major drawing of the lines and everything else, it's not that complicated. All you're looking for is the lower deepest point. So you place your molars there and you look where it starts to arch up on the mandible, so you don't place any occlusion there, so it doesn't destabilize your denture. And you try to make sure you're not too far inward on the mandible, and you try to correct that on the maxilla, making sure that you're not pushing the teeth too far out to the buccal vestibule. Those are the major points that I look for, as well as when positioning lower anterior teeth, make sure the teeth are on the ridge. And if you need to angulate them forward in order to compensate for class 2 occlusion, make sure they're not angled too far past or not past the depth of the lower vestibule. Those are the main points you want to get away from this, okay? Now, when it comes to occlusion, there's a couple of different kinds. Okay, there's going to be semi-anatomic, full anatomic. There's going to be monoplane. There's going to be monoplane balanced, all that stuff. My favorite occlusion, guys, is lingualized occlusion. I'm a big fan of using linguiform teeth. I use VITA linguiform teeth for my posteriors. For my anteriors, most of the time, guys, I will use VITA Pen XL teeth. These are for my premium lines. If I have to do like a temporary denture or like an economy denture, I like to use MFT teeth. Now, MFT teeth are technically semi-anatomic tooth. However, you can set semi-anatomic teeth in lingualized position. All you basically are going to do is you're going to angle it slightly to where the buccal cusp is going to be away, angled away from the buccal cusp of the mandible, and that way it's not going to be engaging. You can actually even adjust it a little bit in order to make sure that just the palatal cusp is working. Now, if the teeth are made, like you can see right here, specifically for lingualized, they will line up like this, like linguiforms do. Some of you guys can utilize a monoplane tooth on the bottom and use a semi-anatomic or a fully anatomic tooth on the top, okay? So there's two types of lingualized occlusion. You have the Gerber lingualized, or just what I like to call regular lingualized. VITA teeth are not Gerber lingualized because in Gerber lingualized, the first premolar is reversed. You see how all of these are going to be central fossas on the mandible and palatal cusps on the maxilla, except for the first premolar. On the first premolar, you're going to have your central fossa on the maxilla and the palatal cusp, or in this case, actually not palatal, but buccal cusp on the mandible. With regular lingualized, it's more simpler. It's just top is palatal, bottom is central fossa. It's just as simple as that. Very important, guys, also to remember that you want to be utilizing overbite overjet, okay? Denture teeth are not made to withstand those kind of pressures on laterally, okay? No matter how good you can have the best denture tooth out there, and if you have too much lateral forces, you can fracture things. You can see that plainly when you're dealing with teeth with dentures that have severely worn out posterior occlusion. Things are going too far on the overbite, and next thing you know, you'd have no overjet, and you're constantly beating on those teeth. Two things will happen. You're going to break some of the teeth, and also you're putting too much force on your anterior maxilla and mandible, causing premature resorption of those ridges, okay? So I always try to build in maxillary and mandibular overbites and overjets, okay? As you can see right here, you got a lot of worn out anterior occlusion, and you can see for this reline, we lost a lot of anterior bone and not too much posterior bone because there was a lot of forces here, okay? And you can see those teeth breaking because of that as well, okay? We're not going to talk about sub-anatomic and anatomic balance occlusion simply because I don't have the time. We're about 5 minutes away from finishing our webinar. What I'm going to do is I'm going to skip forward to lingualized occlusion a little bit because it just works a little bit better for me, okay? Sorry, guys, 1 second. So basically what we try to do is we try to set up our anterior 6 and the first premolars when we're setting our teeth, because what it allows me to do is align things on the mandible closer to the maxilla when I set my first premolars, okay? A lot of people will kind of set anterior 6 or will set all the posteriors as well on the maxilla, or they'll just set anterior 6 here and they'll set all the lowers first. I don't like setting all the lowers first without those premolars, because those premolars will kind of help me align the plane of occlusion. This is what I mean, guys. You see when I'm setting those teeth, this right here from this point allows me to set my occlusal point to the premolar, and from here I can go about 3/4 up to retromolar pad. That would be my plane of occlusion. If I'm just kind of sticking this, eyeballing it, this tooth can be too low or too high, okay? As you can see right here. So what I basically will do is I'll set all my mandibular teeth, except when I'm setting my lower anteriors, I don't worry too much about my overbite position. I worry about my overjet position, but overbite I will adjust in relation to my protrusive movements. So I'll position them properly in overjet, but overbite if they're too tall or too short, it's not a huge problem because this is actually setting my plane. Okay, so once I've set my all uppers, instead of all my lowers, I'll set my upper posteriors. As you can see right here. Now, if I'm having contacts right here, I'll adjust it so I don't have any buccal contacts. And this is where my function is all going to be on my palatal cusp on the maxilla and my lingual fossa on the mandible. And basically after that, after I've adjusted it, I'll start going to protrusive movements and I'll usually drop or raise my anterior teeth. And once everything's balanced, I'm good to go. And I love, guys, I love these Excel teeth. Not because, not only because I'm speaking for VITA. I actually started using these teeth way before I was actually lecturing for VITA. And I was a little bit apprehensive at first, I'll be honest with you guys, because I heard a lot of things like, oh, these teeth are breaking, you get crazy lines and everything else. I have found a really good processing method for making sure you don't break cusps, you make sure you don't break teeth. I basically utilize the same method for processing as they used back in the day when processing porcelain teeth. So when I do my second pour, because I use brass flasks, when I do my second pour, I make sure that the tops of my teeth, right before the stone fully sets, I'll uncover the tops of my teeth. Then I'll put a little bit of separator and I'll do my third pour. And so when I'm actually deflasking things, it just opens up like an envelope and I'm not putting a lot of lateral forces on the teeth. And I've been doing that for, I think, about 6 years now. And knock on wood, I don't have issues at this point. So everything's working pretty good. So I think we're going to stop our webinar right here. We still have a couple of minutes left for questions. And hopefully I didn't go too fast. It's just I really wanted to cover as much material as possible for you guys. But if you are not sure about something, my QR code there has my social media. Contact me. I'll try to answer as many questions for you as possible. Okay.
We have some additional, the rest of the year, we have some additional workshops as well, webinars and so forth. So if you want to come back and visit us for another denture and or CAD/CAM or porcelain course, we have things of that nature. So we have quite a bit going on. So please join us again. We also, if you're interested, we have a denture course for next year, 2024. We've set the dates for the VITA Germany factory workshops. These will be denture workshops. They will be a combination of traditional hands-on, and part of it is going to be just an intro, not really too depth in it, but just an intro to digital as well, because even as Eugene mentioned, you know, there's more and more things that we want to have capability of using a digital process that may be better or at least as good to the traditional aspect. So look forward to that. If you need to get a hold of your local rep, here's a list of that. Here at the help desk, you can always give us a call as well. And then as Eugene mentioned, I put his hyperlink there. If you want to take a picture of it, there it is as well on his card. He is gracious enough to take some calls, some emails from you. Just keep in mind that Eugene has a very thriving working denturist facility and does a lot of teaching, lecturing out in the field a lot. So if he doesn't get back to you right away, just give him some time as well. So let's look at the question sets. Let me pull that up here. We have several questions. So, all right, one of the first questions is going to be, What would be your requirements to have no palate in the upper denture?
Oh, that's a very interesting question. So that's, I have personal experience in that field with my stepdad. So there's textbook and there's what patients will get used to. So my stepfather has an opinion of himself just because he wears dentures, he's a denture expert. So when back in the day, this was like 20, 30 some years ago, no, about 25, 27 years ago. This was back in the day when I was still a dental assistant. He had some dentures made and he could not wear them because of the palatal coverage. He just hated that at all. And he basically did a Dremel adjustment at home and he took his palate completely out and thinned out the denture. And he's gotten used to it so well that there's no actual adaptation, there's no actual suction with that denture, but his facial muscles have adapted so well to it, they envelop that denture that he functions perfectly with it. So my answer to your question is it depends on the patient. If the patient is a huge gagger and they want to just use adhesive on that palateless denture and wear that until their tissues adapt to it and maybe they won't have to use adhesive anymore, then I say go ahead. But arbitrarily trying to cut the palate out unless it's an implant supported prosthesis, I don't recommend because you're not going to have good suction there.
All right. So then a question, how do you control vertical when using a duplicate dentures because you're adding the thickness of the wash impression?
Generally, wash impression thickness is not enough to change vertical that much. Oftentimes with duplicate dentures, you actually will have a collapsed vertical. So it's one of the things I recommend you guys check first. So one of the techniques I'd like to utilize that works fairly well is, you know, I've heard many different things like saying Mary, saying this and the other. I tell my patients to hum because they can hum for a fairly long period of time and for me to record that position. So if they go, they're usually gonna go into vertical dimension of rest at that point, okay? -2 to 3 millimeters there is going to be my vertical dimension of occlusion. And if I check that with an old denture, oftentimes it's going to be diminished about 2 millimeters or so because of the wear out of the posterior occlusion. Now, if you have a denture that's overextended, you can control that by reducing mandibular teeth to collapse the vertical for a little bit, and to account also for the impression material as well. Hopefully that makes sense.
Okay. And then you mentioned a clear compound. They're asking what is the name of that clear compound that you use?
The picture on there, that's exactly the name of it. It's got a long, weird name. I get it from, I used to get it from net32.com. I don't think they sell it anymore. But if you go back in a couple of days on that, well, actually, I can actually just go back on my thing.
The other question is, it's in probably your language, so I can't read it. I'm sorry. Somebody's probably saying hi from Alexandra Metro.
How do I look up?
I don't know if you have access to the questions or not.
Sorry. Well, whoever says hi.
Yeah, that's okay. Can you please tell the flaking method again?
What method?
You have it says flaking, but maybe it's flasking.
Oh, flasking method. Okay. So basically what you do is you do your first pour where you actually set the model into a flask. And then on the second pour, when you're pouring all the stone over the denture part with the teeth and the wax, make sure you pour just a little bit over the teeth. Don't pour too much over the teeth. So basically you're covering the tops of the teeth about 2 to 3 millimeters, no more than that. Now, if you have your denture at an angle, some areas you're going to have more coverage, some you're going to have less coverage. And then depending on the stone you're using, some are faster setting stones, some are slower setting stones. So my stone sets up in about 6 minutes or so. So after about 4 minutes, it'll start getting a little bit thicker. And I'll take my finger and I'll run it right over the tops of the teeth, making sure that I expose just the occlusal and the incisal surfaces of teeth, okay? And I'll let my stone set up. I'll put separator, and then I'll do my final pour over the top and with a lid. So basically what happens after I boil out, press pack, and do everything else, when I'm ready to deflask, I take the lid off, unpack the flask, and then all I'm seeing is just the tops of the teeth showing through. And I take my chisel and I'll start hitting it from the back. I have a pneumatic chisel. I start hitting from the back of the denture, and it just basically opens up like an envelope, okay? I have those videos actually on my Instagram. If you look through my Instagram, through like thousands of posts there, you can find it, or you can message me privately. I can show you those pictures as well. But basically by hitting it from the back, it opens it up as an envelope from the facial, and then you just open up, pop up the third point from the lingual. It opens up in 3 pieces. And that does not cause any kind of extra forces laterally on the teeth, and it doesn't cause them to break. You have to understand, guys, you can't have everything. You can't have your cake and eat it too. Because if you have a tooth that's super hard, because you see on my pictures, I use these teeth a lot of times for hybrids. And for hybrids, I need a tooth that's going to be very well adapted to wear resistance. It doesn't wear away fairly quickly, because with hybrids, they're exerting a lot of forces. There's not proper reception. You want to make sure these things are not going to wear out overnight. So you're going to have this very rigid tooth. When you have rigidity, you're not going to be very flexible. Okay, when you don't have a lot of flex, you can get chipping, you can get fractures like in ceramics, like in ceramic teeth. So in order to minimize that, you need to have proper processing techniques, and then things are going to be good. And that's also why you need to have proper overbite and overjet. And you need to also have proper freedom of movement. If you take Mark Wagenseal's courses or his webinars, he talks a ton about that kind of stuff. He's amazing about talking about occlusion and everything else. I highly recommend you guys do that. And if you do that, you'll be able to properly position your teeth, and it'll work great for your patients, and they're not going to fracture, and they're going to last a very long time.
All right. So if anybody has any last minute questions, please send them in. In the meantime, what is your choice of teeth for crossbite?
I still use my linguiform teeth. I just make sure, don't be afraid to adjust your teeth, guys. Oftentimes we go through this schooling and they're like, the tooth goes this way and this way only, and then you can't be grinding on teeth, especially with these teeth, guys. If you're, for example, if I was using a tooth that had like a composite shell and had the inside with like soft acrylic, I'd be a little worried about adjusting teeth, because once you grind past that hard composite shell, you're into very soft acrylic, and then you're going to have problems. They're going to wear out easily. These teeth are uniformly mixed with ceramic and acrylic. So the positive thing is that you can grind on them as much as you want. You're still going to have a hard shell to them. But the downside is, because it's a hard shell, the bonding is not as great. So you have to have a specific bonding protocol when you're processing these type of teeth. My thing is, I make sure I steam clean everything. There's no wax. So I do my regular boil out like everybody else. But after that, I'll make sure I steam clean everything. I clean everything up with monomer. And about 5 minutes to 10 minutes before I start press packing, I will apply what's it called? VITA to it, because it has that little softener as well in it. It has a wax solvent and a softener that will actually soften that. And I have really good bonds. Like I mentioned to you guys, I do hybrids. So you want to make sure things are really well bonded. So if you follow those protocols, guys, you're going to have success. If you guys can just wing it, I guarantee you guys, you're going to have issues. Okay?
Yeah.
So make sure in crossbite, set them and adjust the cusps as necessary, making sure now at this point when you're dealing with crossbite, you no longer have a palatal cusp that's going to be functioning. It's probably going to be your buccal cusp that's going to be functioning, right? So also make sure that when you're setting your teeth, they're set closer to the ridge when that's done. Because if you set your teeth too far onto the buccal and you have a lot of function on your buccal cusp, and it's actually going to be the depth of the vestibule, now you're going to have disbalance in your dentures.
For those friends of ours in Canada that we don't have VITA available, yeah, they Health Canada has some things about
Those
chemicals.
Man, I'm telling you.
Probably just monomer, right?
No, they actually have. I think they use Palabond over there.
Palabond.
Yeah, I don't know what the consistency of it is. I've never used it myself, but they. I talked to our VITA reps in Canada, and they they actually recommend a pallet bond for the guys that can't pallet.
All right.
I mean, not pallet, but VITA call.
All right. Well, thank you again, Eugene, for taking your time out of the day and giving us a tremendous amount of knowledge. We greatly appreciate it. Thank you, everyone, for joining us today. Again, you can rewind and review this webinar at a later date as soon as we post it. And Eugene, any last thoughts before we leave?
No, thank you so much for this opportunity, guys. As always, we're great to work with you guys, and you always give me these cool assignments that I can do, and I really, really appreciate it. And for everybody watching, thanks so much for attending, taking the time out of your busy day. And if you have any questions, something will come up down later when you start doing things, or maybe when you're reviewing the webinar, because I kind of went pretty quickly because I wanted to cover a lot of information. Please feel free to message me, and I'll try to help you as much as I can.
All right, great. So this will end today's VITA Academy webinar. Everyone have a great day wherever you may be, and we'll see you next time.
See you next time.
Thanks for joining.